just a question. Please answer in the chat box. It can have multiple options. Okay, whatever you feel is the current scenario for nailing in proximal humeral fractures. Okay, we are talking of partial articular and interarticular fractures of proximal humerus, not the shaft or the metaphyseal region as such. Okay, so whatever you feel, I will give you a couple of minutes for this. Answer could be 1, 1, 2, 1, 2, 3, whatever you feel. Please put it in the chat box, and after that we will proceed with the talk. Naufal, if you could just read the answers because I can't see the.
Definitely, sir. Yes, sir. I was about to do that. So the first one is can be used in all types of proximal humerus fractures, can be used in all 2-part and selected 3-part fractures, has poor functional outcomes as compared to the Philos plate, is biomechanically inferior to the Philos plate, has more complications as compared to the Philos plate. Now the options given by most of the students include number 2, can be used in all 2-part and selected 3-part fractures. Some people have chosen 2, 3, 5, 2 and 4. Someone has also told is biomechanically inferior to the Philos plate.
Anyone who selected 1?
No, sir.
No. Fine. So that makes my thing pretty easy, right? Okay. Fine. So let us just see how this is. When we talk of treatment of proximal humerus fractures, like what Dr. Naufal mentioned, there are various options, and each of these is good enough. Okay, if you see the literature, each one will vouch that it is superior to some other form of treatment. We have conservative management, we have K-wires and modifications of K-wires. We have the rest technique, we have just fixations, we have rushed nails also. Okay, and the plating mostly with Philos plate. Now most other plates are not used currently. The anatomical locking plates is what we use, and it is considered as a gold standard in the sense, just like what Professor Gopkumar told, it is giving consistently good results over a period of time across all centers. Okay, and that is what you want as a gold standard, that whether a senior surgeon does it or a junior surgeon does it, it should give significantly consistent results. So that is what you expect out of a good implant, and that is what has stood the test of the times, in so much so that Philos, which was released, if I'm not wrong, in 2002, doesn't have any more generations to that, in the sense that that is the first and the last. So there is no more modifications which we see. Now when do we see modifications in an implant? We only see modifications when the existing implant has some issues. That is when you see some modification being done and the next generation of the implant being released in the market, but it's just not there in the market. That means this is helpful, beneficial to all the surgeons, right? So that is the gold standard. And then we have the arthroplasty also, especially in the elderly, the unsalvageable ones. We could think of arthroplasty. Hemi, not so much. Reverse shoulder is coming in a big way in many centers, including India now, for most of these fractures, because it is much giving a much better functional outcome. Hemi, as such, is more or less a failure in proximal humerus. Okay, but what about the nail? Most of us, or even in books or in the literature, we hardly think about the nail as a treatment option for proximal humerus fractures. Now, why is that? Why don't you even consider nail as a good treatment option for proximal humerus? All right, it might have its problems, but we are not considering it. Okay, so this is because of the very bad history which is there with the proximal humerus nailing. Exactly like what Professor Gopkumar sir told, that you ask any of the senior surgeons who has done at least 1 or 2 nailings with the previous generation nails I'm talking of, they have had huge complications. What are the complications? There were varus collapse, there was avascular necrosis, there was screw cutouts, screw cut throughs. Okay, so all these were disasters, and even in those patients who went on to heal nicely, the implant just did not budge, there was no cutout. But even then, just a minute, yeah, even then the issue was with the entry point. The entry point was right at the footprint of the rotator cuff attachment. Now at this time, whether during your entry or during your reaming or during passing your nail, all this time the rotator cuff gets chewed off, and we know that the patient will have a painful shoulder, no matter how excellent the implant has behaved, how excellent the union has occurred, but the patient will have a painful shoulder, which is much more troublesome than a non-union. Okay, that is exactly why nailing was more or less abandoned. Now, if you see before 2015, nailing was not even considered as a option, and that is what is sticking even in most surgeons' mind even today. But the problems faced with the nailing as such in proximal humerus, if you can enlist them, there were basically 4 problems. The first problem was with the entry point. Now, this was the entry point with the original nail design. Okay, so this is the sulcus where you're entering. So we all know that rotator cuff comes and just attaches over here. Now, when we tell that the rotator cuff attaches to the tip of GT, it is not a point attachment of muscle. The muscle broadens, it goes into it widespreads and attaches. Okay, so all this area will be covered with rotator cuff. Now, invariably, this will be damaged. Okay, either during entry or during reaming or whatever, it will be damaged. That was number one problem. The second biggest problem was with regards to reduction. We are entering with a nail on the lateral side, and it always tends to drift into varus. Now, this is the problem we see even with subtrochanteric fractures, correct? In a subtrochanteric fracture, a nail, more often than not, you are going to end with varus malangulation. The third biggest issue was with regards to tuberosities repositioning. Now, look at this. The surgeon has done a good job with regards to the reduction of the fracture, but the nail is exactly occupying the place where the greater tuberosity should come back and sit. Okay. Now, if the nail is occupying that place, there is no way the greater tuberosity will come back and sit over there. So that is exact. That means that tuberosity will be fixed in a non-anatomical positions. And now we know that tuberosities, if it is not healed perfectly in its anatomical location, these patients will definitely lose significant range of movements at the shoulder, and they will be unhappy. So this was the third issue. And then screw cutout as such, especially in osteoporosis, not just with related to nail, even with plates we do feel, but with nails it was much more commoner, because these screws, these were bolts, these were not any purchase in the bone. So with even minute degree of osteoporosis, they used to cut out. So these were the 4 big problems associated with the nail. That is why nailing was abandoned. Okay. Now, I mean, we have experience only with this multiloc nail, but to put it in a broader vision, any of the second generation humeral nail. Now, what is the second generation humeral nail? It is the straight nail design. Okay, so this particular nail is a multiloc nail of Synthus, but you have other companies' nail also, which is basically a straight nail design. Now, this is the current scenario of the nailing in proximal humerus, and this has taken care of all the issues that were there with the previous generation of nails. How? We will just have a look. Look at the entry point. The entry point is much more medial to the sulcus. The sulcus is somewhere there, whereas the entry point is medial. This is in line with your shaft. Okay, so at this point there is absolutely no rotator cuff. So you are taking a split in the tendon of the rotator cuff, going in and doing all the instrumentation and implantation that needs to be done. So there is no direct damage to the rotator cuff. So the biggest problem is taken care of, number one. So this is where the entry point is. We could see this is the sulcus, and this is where the original nail design we used to enter. But the newer nail design, the straight nail design, we are going much more medial to that, and there is absolutely no muscular attachment to this part. Of course, there is an articular cartilage. I will come to that. What happens to that? But the muscle part, the rotator cuff part, is taken care of with that. In lateral view, it is in line. It is in the middle of the shaft. Okay. What about the reduction? Now, I gave you an example of a subtrochanteric fracture. We have all faced this issue, right? Whenever there is a subtrochanteric fracture, we use a nail, we use a lateral entry point, it invariably drifts into varus. And what is the easiest way to overcome this? You just need to take a much more medial entry point, even the piriformis fossa. I'm talking of proximal femur, okay? So you medialize your entry, automatically the varus malalignment will be taken care of with the same nail. You don't need to do anything else, okay? The same concept, if you extrapolate over here, we have already medialized our entry point as compared to the older generation nails. So varus malreduction is no more an issue in treating these fractures. Okay, so the second problem is also taken care of automatically. So this is the example. This is the previous generation nails. We had a lateral entry point. These things used to drift into varus, whereas the newer generation nail, much more medial entry point. The varus malreduction does not occur. Okay, in fact, it goes into more valgus. Okay, as we can see, I'll show you some case examples. What about the tuberosities repositioning? Like told, the previous nail design used to exactly sit. So many times what happens is, in an AP view, the tuberosities look good. With the previous nail design I'm talking of, it did look good, and the surgeons did not take the other view, which is actually difficult to take intraoperatively. But postoperatively, when you do it, you realize the tuberosities is off. Okay, so if it is off in that view, that means even if it malunites in that particular position, the patient is not going to do good. Now, this is not a concern with the current generation nail because we know that we have a much more medial entry point. So we have enough room where the tuberosity should come and sit back. So there is no obstruction for the surgeon to reduce the tuberosity back to its anatomical location. Okay. Yeah, and the previous generation nail used this screw-like thing, which is called a bolt. Okay, this had a pointed tip, and what happens is many a times when we try to put this screw into the nail, because of this pointed tip, there will be a significant pressure over the area, and GT used to splinter. Now, most of the patients, the GT is a thin, flimsy bone. Okay, you need to handle it very very carefully, otherwise it's going to splinter. Going to combination intraoperatively, which used to be a big problem with the previous generation nails. But the current generation nail has this type of a conically tapered bolt. Okay, because of this conically taper, the pressures are extrapolated over a bigger, wider surface area, so there is no more splintering occurring. Okay, and this design I will talk about it. And the point is not a tip; it is more blunt. So that is why you most of the time will not have combination intraoperatively of the GT. Okay, so that all those things are taken care of. Plus, we can see these bolts have these holes. Someone is drawing, I guess. Okay, you could see these holes in the bolts. So through that we can anchor the tuberosities back to its position. You could use either an bond or a fiber wire or any suture material of your choice. And this is very similar to your Philos plate. Now Philos plate also has these holes provided so that you could anchor back the tuberosities. The tuberosities have to be anchored to its back to its anatomical location, and it needs to be sutured properly. Otherwise, it will fly off, and the patient is not going to have any movements in his shoulder. Okay, so all those provisions are provided even with a nail. Plus the screw cutout, which was a big challenge with the previous generation nails, is no more of a concern now because of this what is called this screw in screw technology or screw in screw design. Okay, so we have the main bolt and the other locking screw which goes through the main bolt and locks into the head. I will show you a video how exactly this is done. Now, what is the advantage of this is that this is at a trajectory of about 40 to 45 degrees to each other. So it is practically impossible for any physiological force to back out both the screws. Now remember, any screw through any implant, whether it is a plate or a nail, can be backed out by simple physiological force acting perpendicular to the alignment of the implant. In the sense, you have a plate, you have a screw there. All you have to do is put perpendicular forces against the implant; it will back out. Even physiological forces. I'm not talking of pathological forces. Okay, but when you have this type of a design which is going in different directions, you can't envisage any particular same force acting on perpendicular to both of this. Okay, because it is in a different plane, so it is practically impossible for physiological forces to back this out. This has been proved, and we'll just show you. Okay, plus very very much similar to your Philos plate, we have the screws going into different areas of the proximal humeral head, so that any part of the bone, we know that in the posterior part is the one which has the maximum strongest bone in the humeral head. So even we have screws going into that trajectory. Okay, so this was not there in the previous generation nails. We had two at the most, three screws, all going in very much similar directions, all taking the same part of the humeral head. So here we have a widespread array. So we have much better purchase. So all the screw cutouts could be prevented by this. Okay, and then the kickstand screw. Now this is borrowed from the Philos plate. The biggest advantage of a Philos plate. Now, why is Philos plate such a success? Is not because of anything else, but it is at least 80% attributable to this one particular kickstand screw which is there in the plate. Okay, so you do a non kickstand screw type of a plate, or you put a Philos plate and do not put this screw, then many of the times you are going to have a varus failure. Okay, so this concept is borrowed from the plate and incorporated in the nail. So whatever advantages that you can perceive to be there in the plate has been incorporated in the nail. Plus, nail has its own advantages. So that is why it is slightly becoming better than a plate. Why? We'll come to that. Okay. This is the bushing that is seen in the nail, which gives extra purchase to the screw. We'll come to that in a video. You will get to know. Now, look at this video. This is a ETN nail, the expert tibial nail. The screw just pops in and out of the nail. So there is no inherent purchase to the screw, right? So any screw can just go in and come out with minimal forces involved. whereas this is a multiloc nail. You could see a white lining there, that is a bushing in the nail. The bolt which is provided cannot be just pushed in or pulled out through the nail. Okay, it needs to be screwed in inside the nail. So you have the particular screwdriver, you can screw it in, so that what happens is the bushing gets expanded, the bolt goes in, and then the bushing gets compressed over that. So you have the inherent stability of the bolt within the nail, although there is no bone anything surrounding that. Okay, so it has an inherent stability. So this is one excellent thing that can be used even in significantly osteoporotic patients. Okay, now once you have screwed this in, there is no way we can pull it out. Okay, they have tested this, and 6 times the physiological forces also, if you use, it will not be coming out. Okay, so see that no matter how hardly you tap it out, it doesn't come out even a single thread. Now, that is the biggest advantage. There is no way screws can cut out of a properly done nail, this generation of nail. Plus this screw in screw, you could see that screw going from into the first bolt, going out of the nail and capturing some other part of the humeral head. Okay, and it locks into the golden color bolt. We'll see that from some other direction now. Some other plane. Yeah, you could see that it's going at a different plane, different trajectory. So there is no way any force which will come perpendicular, which can act perpendicular to both of these. So, okay. So even if there is a force acting perpendicular to the green screw, it will not be perpendicular to the yellow screw. Okay. So there is no way a force can cut out both of these together. So that is the advantage of this particular design. Okay. So we have seen how the nail design has been changed to incorporate the different good attributes that we can attribute to a plate, plus taken care of all the problems that were there which we could relate to a nail with the previous generation nail. So the design has drastically changed. Now, with just by changing the design of an implant, does it change anything? Does it become a good solution for treating proximal humerus fractures practically? So that is what we need to think about and we need to understand. Now, what we are comparing to is only with the plate, because plate is the gold standard. Okay, plate is definitely the treatment of choice for most proximal humerus fractures. If you take an opinion of all the orthopedic surgeons across the world, it is the plate. Okay, so this is the gold standard.